My God, why don't we avoid it and just study GI bleeding twice? Because the tests are getting harder, but so are you. The commonest type of valvular disease here, congenital valvular disease, is the bicuspid valve. Now, the bicuspid valve is not just like the mitre, where a mitral valve is just two cusps as well, but they're two individual cusps. What it is one of them just fails to open. It's the imperforate hymen of your heart. The raphe, not the Raffles, the raphe are bound to each other. And this congenital abnormality, what is true about congenital bicuspid aortic valves? Which is this is true? Is it the rate of aortic stenosis? Is it the same as a normal valve? I doubt that very much, because that looked pretty evil. Can it lead to aortic regurgitation? Does endocarditis prophylaxis needed? Endocarditis prophylaxis not needed. We already said previous endocarditis, unrepaired cyanotic heart disease. Is this a cyanotic heart disease? It's not cyanotic. It's not cyanotic. You just get short of breath. So previous endocarditis, unrepaired cyanotic heart disease, transplant recipients, and people have prosthetic valves. So endocarditis prophylaxis not needed. A transthoracic echo, we'll see it. You don't need a transesophageal, and you do get chest pain, you do get syncope, but the difference is that which of these is true is that it eventually dilates up. You see that? It's dilated. It eventually dilates up and gets angry at you, and you go to aortic regurgitation later on. It eventually gets tired and dilates. So, the management of bicuspid aortic valve with mild aortic regurgitation and no symptoms. What are we going to do about mild aortic regurgitation, no symptoms? TE every year, transthoracic echo every year. What are you going to do? Transthoracic echo every 3 or 5 years, or replace the valve now? Ooh, it's a transthoracic every 3 to 5 years. I know, doesn't it seem picky? But you've got to learn it. For the MIXAP tells me so. And also remember that our internal medicine boards are having things on them that used to be considered in subspecialty boards like cardiology. So if you used to think that this should have been cardiology boards, well, too bad, it's internal medicine board now. I'm sorry. My cuspid valve with aortic regurg is present, but no symptoms. The aortic root is 6 centimeters. What are we going to do about a 6 centimeter aortic root? How bad is that? 6 centimeters. 6 centimeters. Well, we operate on aortic aneurysms at 5 and 5.5 centimeters, but maybe it should be wider up at the top. And the answer is, actually, that's actually the whole point. It's even worse up there. We operate on aortics at 5.5, but here surgical valve replacement because it's above 5 centimeters. When it dilates up to above 5 to 5.5 centimeters, depending on how fast it dilates, it's the same number that you can memorize for the abdominal aortic aneurysms. So for the abdominal aortic aneurysms, we say 5 centimeters, 5.5 centimeters, and here 6 is clearly a surgical valve replacement. Ooh, isn't that beautiful? What a beautiful image. Ooh, it's like the inventing room in Willy Wonka. Ah, if you want to view paradise, simply look around and view it. Yes, that's the dilated, that's the congenital bicuspid aortic valve. BAV, bicuspid aortic valve. There it is, and it's dilated up there. Ooh, I'm impressed. Yes, that's the look of aortic regurgitation. A 25-year-old female who's got worsening exertional shortness of breath, and she's got a 3/6 systolic murmur at the upper right sternal border. 6 upper right. What's up there, the upper right? Ooh, APTM. No, wrong side. APTM. I don't know. Aortic pulmonic tricuspid and mitral. Aortic pulmonic tricuspid and mitral. Aortic pulmonic tricuspid and mitral. Oh, and the TTE is showing a bicuspid aortic valve. Valve gradient is 45, 54. 54. Ejection fraction 45%. How bad is that? What are we going to do for this when we've got a 54 millimeter of mercury valve gradient? What's a normal valve gradient? 0. It should be 0. There should be no gradient. Now I will tell you, management of aortic stenosis, upper right border, aortic stenosis. Remember what we said in the dim dark past, the last section of valvular heart disease? We said that stenotic lesions, any symptoms, need replacement. stenotic symptoms replace. ACE inhibitors, we said, are dangerous in aortic stenosis. Nifedipine is vasodilator. It's dangerous. Vasodilator therapy, ACE nifedipine is for regurgitant lesions. This is a person who simply has symptomatic exertional dyspnea, symptomatic aortic stenosis, so it's time for it to be replaced. And remember, balloons are only if you can't do aortic valve surgery. What's the most commonly associated with the bicuspid aortic valve? Oh, is it coarctation? Is it mitral valve prolapse? Ventriculoseptal defect? Coarctation, you're gonna get that one right because that's back from the step 1 USMLE part of your brain. Remember that? What's associated? This is just another congenital abnormality that is associated with bicuspid aortic valves. You either know it or you don't. What is this disease? Best heard auscultating in the back. What is that? That figure 3. You see the figure 3? The figure 3. Is it an ASD? Is it a ventriculoseptal defect? Is it an ASD, VSD, patent ductus arteriosus, or is it a patent foramen ovale? It is a, oh, that's it. That's what coarctation looks like. That's what coarctation looks like on a chest x-ray. That's what coarctation looks like on a chest x-ray. Aha, that's it. Oh, what is it? It is, it's an atrial septal defect, or is that a patent foramen ovale? A patient comes with an atrial septal defect. It comes for evaluation. She's asymptomatic and has a pulmonary systemic flow of 1.3 to 1. Oh, is that bad or is it okay? 1.3 to 1 is not bad. That's tiny. That's tiny. Which one's more common? Patent foramen ovale or atrial septal defect? Patent foramen ovale is more common. Which one is more likely to be open? Oh, I'm not going to tell you, but I will tell you that for this person who's got just a little bit of pulmonary systemic flow abnormality, that in this person, by the way, when you close it, this is too minor. So under 1.5 to 1, under 1.5 to 1, you can go ahead and get pregnant. It's insignificant. Because remember that if you get pregnant, you get this huge increase in plasma volume. So what ends up happening is you can get more shunting of blood that ends up being unoxygenated because the right side of the heart fills up and you'll end up having more flow unoxygenated bypassing the lungs. So at 2 or above, at 2 to 1, at 2 to 1, you definitely have to close it. Under 1.5 to 1, you definitely don't have to close it. What are you supposed to do for in between there, 1.5 to 2? Not so clear, but your boards have to ask you a clear question. And it is a super clear question that says under 1.5 to 1, you don't have to close that atrial septal defect. A patient's on long-term parenteral nutrition and has a cardiomyopathy, and it's not thiamine deficiency, not thiamine, but a cardiomyopathy, a micronutrient deficiency. And that micronutrient deficiency is, which micronutrient? It's selenium, which if you weren't preparing for boards, would you have known that? Well, interestingly enough, most of the people at internal medicine board level know that question. Why do they know that? Have you been seeing a lot of selenium deficiency? Do you have a selenium deficiency unit at your hospital? And the answer is no, it's because we're preparing for boards and we love the boards, because if it wasn't for preparing for the boards, we wouldn't study hardly anything and we'd never learn about congenital heart disease. What's the most common problem after the surgical repair of tetralogy of Fallot? Now you might say, why are you asking me this question, Conrad? After all, I don't manage little babies with tetralogy of Fallot. That's right, you don't. You manage them as adults who have been successfully repaired. Now what happens to the little blue squatting baby? He squats and he runs and he squats and he runs and he squats and he runs. Now what happens to the little blue squatting baby that's now all grown up and is now 40? Pulmonary regurgitation as an adverse effect, as a long-term consequence of the repair. Holtorum. Ay, ay, ay. Holtorum. That was why I was preparing you on the selenium deficiency. Holtorum is an ASD in association with Holtorum presents with adults who are having a difficulty masturbating because they go to try to masturbate and their arms only have one bone. You're missing your radial bone. So since you're missing the radial bone, you're having a masturbation difficulty because not only do you have the ASD, your hands keep spinning around. Holtorum. Oh, ho, 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 look at this. Oh, ho, ho, ho. I feel like I'm missing. I feel like I'm missing something. Yes, it's a funny thumbs and a missing radius bone. Whew. For some people. Wow, that's terrible. What's the major difference between a patent foraminal valley and an atrial septal defect? The major difference between a patent foraminal valley and atrial septal defect. Only one of these associated with a stroke. Nah, they're both associated with a stroke. Only one can be closed with a catheter device. No, they both can be closed with a catheter device. ASD is more common. Is an ASD more common than a patent foraminal valley? ASD is always open. Which of these is the right answer? Patent foraminal valley has abnormalities on EKG. Patent foraminal valley doesn't have abnormalities on an EKG because there's not enough flow and pressure abnormalities. There's not enough flow and pressure abnormalities to create aortic atrial enlargement. So since there's not enough flow and pressure abnormalities to create atrial enlargement, the biggest difference between these is that the atrial septal defect is bigger. The atrial septal defect is more likely to have abnormal flow. Patent foraminal valley is present in 1/3 of the population. Is it even a disease? Well, it's hard to say it's a disease if 1/3 of the population has a patent foraminal valley. Now, they both can be associated with stroke. They both can be closed with catheter devices. ASD is much less common in a patent foraminal valley, but the ASD is more likely to be always open. So when should you close the atrial septal defect? Stroke. Right-sided chamber enlargement. Well, it's associated with stroke. I don't want a stroke. Do you want a stroke? So it's associated with it. Pregnancy. Well, it's not pregnancy unless there's a certain amount of abnormality of flow. Remember, 2:1 of pulmonary systemic flow. Or left ventricular hypertrophy. Well, why would a defect that's inside the atria, in the atrial septal, why would an atrial septum defect cause a ventricular abnormality? And the answer is it wouldn't. But what happens is that if you have left to right flow, because which side of the heart has greater pressure? Which side of the heart has greater pressure, the left or the right? The left, exactly. It's like saying which is bigger, your tricep or your quadricep. Your quadricep is bigger because it does more pressure work. So if you start to have left to right flow, it enlarges the right side of the heart. Left to right flow abnormally changes the shape. And if you change the shape, it's time to close it. And this is how we close it. We close it by putting a catheter through the hole in the heart. We put a catheter through the hole into the heart and then basically pull it together. Basically, it's like putting a button. It's like putting a button in there that just seals the hole shut. Isn't that cool? I think it's amazing. It's the Department of Amazing department. Okay, which of these associated with a cleft mitral valve? I didn't even know there was such a thing as a cleft mitral valve. What's a cleft mitral valve? Why are you asking me, okay, which of these associated with Down syndrome? And the answer is, well, which is generally worse, a primum or a secundum atrial septal defect? What's generally worse is the primum defect. The secundum is not as bad, and it has to do with the location. It has to do with the location of how low down it is in the atrial septum. The primum defect is lower down and therefore closer to the ventricles. And the primum defect is the answer to both of these questions. You might get asked either one of them. How do you know which of these questions you're going to get asked on your test? They might say, put you on your question and say to your question, which of these is associated with a cleft mitral valve? And the answer is primum defect. Which of these is more often associated with Down syndrome? And the answer is a primum defect. Which one will you get? You don't know. And you don't care because you are going to be able to answer all of them. Maternal rubella is associated with, it's too hard, it's too hard. No, you're going to be able to, by the way, the expansion of the course is meant so that you could go through all the questions in everything and should be able to answer 90% of them, because you'd say, this is sort of the stuff that if you weren't studying for boards, you'd never get to. Maternal rubella is associated with, I don't really like any of those choices. Gee, what are you supposed to do? Oh, it's like speed dating at a place with a lot of ugly people. There's a lot of choices. I don't like any of them. And that's because that's the one I want. I want patent ductus arteriosus. That's what maternal rubella is associated with. Maternal rubella is associated with an abnormal connection between the aorta and the pulmonary artery, between the aorta and the pulmonary artery, because that should close off. You see, that shunt is normally inside babies. That shunt is inside babies because that's how the babies are able to bypass the lungs. Because in babies, the lungs are squished and they're filled with water. They're filled with fluid. They're filled with fluid, so we don't want the blood to go through the lungs. We want it to bypass the lungs and go straight into the aorta, where it can get oxygenated at the umbilical. But here, if that's left open, you have an enormous left to right shunt, and that ends up having to be closed at birth. So you can use non-steroidals or surgery to close the patent ductus arteriosus. Now, which of these are contraindication to the closure of a ventriculoseptal defect? A congenital ventriculoseptal defect. Because there's no contraindication to the closure of one that's in adult, because you're going to die, because it's usually from an infarction. In adults get a ventriculoseptal defect by infarcting it. But in babies, what's the contraindication? Let me think that through. Pulmonary systemic flow less than. Well, I don't think it could be less than. Greater than sound more evil, right? History of endocarditis. In babies, not closing goes to history. How's the baby getting an endocarditis? Eisenmenger's. Eisenmenger's means pulmonary hypertension. Pulmonary hypertension. So, poor exercise tolerance. Well, that would seem to be a reason to close it, not a contraindication of closing it. So the reason that you would not close it is if it's Eisenmenger's, because Eisenmenger's means that the left to right shunt has become a right to left shunt from pulmonary hypertension. So if you have such severe pulmonary hypertension and you close the ventriculoseptal defect, where's the blood going to go? It's not going to end up being able to get into the pulmonary artery. So Eisenmenger's has to accept the fact that there's going to be some right to left shunting. Is that cyanotic or not cyanotic if it's right to left shunting? It accepts the fact that there will be some right to left shunting, and because the reason that you can't close it is because if you close this septal defect and the pulmonary artery is super tight, you won't be able to oxygenate at all, and you're going to die. Okay, which of these is the strongest indication for the closure of a patent ductus arteriosus? Right ventricular enlargement, left ventricular enlargement, pulmonary hypertension, or calcification of the patent ductus arteriosus? The strongest indication. Calcification, no, I'll close that, I'll cut it off. Pulmonary hypertension, left ventricular enlargement. So left ventricular enlargement is an indication because that left ventricular enlargement means the shunt has changed the shape of the heart. So if there's enough shunting that it's changing the shape of the heart, it's an indication to close it. Oh, Look at this. What's the difference? I know this is hand and foot syndrome. No, what's the difference in these pictures? What's the difference in the pictures? The color of the hands. You see, did you notice that one of these, paler, darker, paler, darker, paler, more cyanotic. So what is this? When is Eisenmenger's associated with cyanosis, meaning decreased blood perfusion of the feet? Nice, healthy, perfused hands, unperfused feet. When is Eisenmenger's associated with this? So where it's cyanosis of the feet, blocking perfusion of the feet. ASDs seem kind of mild. Coarctation, but it's still a patent ductus arteriosus. A patent ductus arteriosus where the hands get enough perfusion and the feet don't. Wow, let's absorb that. Isn't that amazing? So a man comes to the emergency department with 1 day of chest pain. The pain worsens when he takes a deep breath and when he goes from a sitting position to a lying down position. I think this is pericardial disease. Do you know how I know that this is most likely to be pericardial disease? How do you know this is pericardial disease? Because it says pericardial disease on the top of the slide. That's how you know, okay? The other thing is, now that you've survived all that painfully difficult congenital heart disease, now we have it where we're saying to you that it's pain that's pleuritic and positional. Pain that's pleuritic and positional, okay? So it gets worse with breathing, and also when you lay back, you stretch the pericardium. When you lean back, you're stretching the pericardium. It's better. Pericardial disease. What's the best initial test? It's an EKG, pericardial disease. The most common cause of pericarditis? Any infection, but viral is the most common. Any infection, Staphylococcus, Streptococcus, syphilis, CMV. Any infection, gram-negatives or fungi or rickettsia, but viruses is the most common. Any connective tissue disease, rheumatic fever, rheumatoid arthritis, scleroderma, Sjogren's syndrome, lupus. Any connective tissue disease, but lupus is the most common. Any trauma, penetrating trauma, blunt trauma, emotional trauma causes pericardial disease. Any infection, virus the most common. Any connective tissue disease, lupus is the most common. Any trauma. And cancer, what kind of cancer can cause the pericarditis? I bet you want to say any. No, it's not any. It depends on what's nearest your heart. Can penile cancer cause pericarditis? It depends on what's closest to your heart. But the things that cause pericardial disease are the organs that are closest to your heart. Lung, breast, lymphoma, esophagus, 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 because what's near the heart? The lungs, the breast, the mediastinal lymph nodes, and esophageal cancer. Lung, breast, lymphoma, esophagus. No, the most specific finding means that it's only in this disease. ST elevation is found, but ST elevation can be found in ischemia. The most specific that's only found in pericarditis is PR segment depression or PR segment prolongation. And the answer is depression. PR segment depression is the most specific finding because it's not found in the other illnesses. ST segment elevation is there, sinus tachycardia is there, but PR depression, see the PR is low, depressed, low, depressed, low, PR, depressed. It's only PR depression in someone who's got pericardial disease, PR depression. So the best initial therapy for pericarditis is non-steroidals. And if the non-steroidals do not work, what you will do is you will add steroids, you'll add glucocorticoids. Non-steroidals is the best initial therapy, a little Motrin, a little Advil, ibuprofen, naproxen, Sulindac. Meloxicam, it doesn't matter which one. It doesn't have to be indomethacin. Any non-steroidal, they're all the same. And if that doesn't work, steroids. Now, patient with recurrent episodes of pericarditis that has been on non-steroidals and steroids several times, what do you do to prevent the next one? Interestingly, this is a bit of information that's only been known for about 10 years, and interestingly, everybody seems to get this one right. I don't know why, but everybody seems to know that adding colchicine decreases recurrences of pericardial disease. Why does everybody know that? I don't know, but they just do. It's colchicine, anti-inflammatory. Oh, what is this? I know, it's an EKG. What is it that you see on the EKG? Ooh. All of these are QRS complexes. QRS, 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 QRS. But you got a big, small complex, small complex, big dog, little dog. Do you like my hat? Small dog, small dog, big, small, big, small, big, small, big, small. This is called electrical alternans. This is from a heart that's flopping backwards and forwards in the chest, flopping backwards and forwards in the chest. And the heart is flopping backwards and forwards in the chest. And when the heart flops forward, the complexes get big. And when the heart flops backwards, the complexes get small. And why is this heart flopping forward and backwards in the pericardium? It's flopping forward and backwards in the pericardium because it's pericardial effusion, pericardial tamponade. What is tamponade? What not tamponade? Why don't we drink lemonade and treat tamponade? And the answer is because lemonade is an American word and tamponade is French. Tamponade is French. So you're compressing it, and it's flopping backwards and forwards. You're in a motor vehicle accident and you got shortness of breath and jugular venous distension, hypotension, tachycardia, hypotension, distended neck veins, tachycardia, hypotension, distended neck veins, tachycardia, hypotension, distended neck veins, but that can be pulmonary edema. How do you tell the difference between that and pulmonary edema? Tachycardia, hypotension, distended neck veins, pericardial tamponade. Tachycardia, hypotension, distended neck veins, that could be pulmonary edema. How do you know this one is tamponade? And the answer is clear lungs. You see, pericardial tamponade has clear lungs because you can't have congestion if you can't get fluid into the lungs. The most specific physical finding, well, tachycardia and hypotension and distended neck veins are not specific. They're not specific. Hypotension is not specific. An S4 gallop is not found. An S4 gallop is a sign of atrial systole against a stiff, non-compliant left ventricle. An S4 gallop is atrial systole against a stiff or non-compliant left ventricle, and you don't find that. An S3 gallop is a sign of rapid ventricular filling. It's a splash, it's a splash. S3 gallop is a splash on congestive failure and pulmonary edema. Decrease in blood pressure of 10 millimeters on inhalation. It's this one. It's decrease in blood pressure when you inhale. What's the other name for that? Decrease in blood pressure of 10 millimeters when you inhale. It's also known as pulsus paradoxus. Everybody's blood pressure decreases when you inhale. Did you know that your blood pressure decreases when you inhale? Because when you inhale, the lungs get bigger and fill up with fluid. And therefore the blood is not going into the heart. So there's a 5 millimeter, a 4 millimeter, a 6 millimeter decrease in blood pressure, but not 10 millimeters. Now, how much blood pressure do you need to feel a radial pulse? Blood pressure of 70, 80, 90, 100, 120? You need a systolic pressure of about 90, depending on your body size, to feel a radial pulse. Now, what would happen in tamponade is that when you inhale, what happens is that venous return comes into the right side of the heart when you inhale. But since the heart can't just get bigger in external diameter, the right side of the heart filled and squished the left side. So the blood pressure can drop 15 or 20 millimeters of mercury. So what happens in a pulsus paradoxus, your systolic blood pressure can go from 110 to 80. From 105 to 85. And when you inhale, your pulse disappears. You exhale, pulse comes back. You inhale, pulse disappears. You exhale, pulse comes back. Ooh. Your pulse disappears, but you're still alive. My goodness, that's so paradoxical. You have no pulse, but you're alive. Now what's this one down here? An increase in jugular venous pressure on inhalation. Whose sign? Kussmaul's sign. Kussmaul got around. We have Kussmaul's breathing, Kussmaul's this and that. And an increase in jugular venous pressure on inhalation is a sign of constrictive pericarditis. Constrictive pericarditis is like having concrete boxer shorts. You want a lot of room in there, but it calcifies and fibroses and gives things a squeeze at the wrong time, and you have an increase in jugular venous pressure on inhalation. That's Kussmaul's sign. But what you get in tamponade is pulsus paradoxus. Now this is pulsus paradoxus. Pulsus paradoxus from tamponade, here's the tamponading fluid. The tamponading fluid is compressing the heart. So when blood comes into the right ventricle, it goes into the right ventricle, what happens is it squeezes the left side of the heart. The blood comes in here, you're tamponaded, the blood comes in, the right ventricle gets larger. See how the right ventricle is getting larger? The right ventricle gets larger because you inhale and it squishes the left ventricle. So pulsus paradoxus is squished left ventricle syndrome. But you live off the output of your left ventricle, and that's why you lose your pulse. What's the most specific EKG finding in tamponade? Oh, could it be that thing that we showed you before? Not PR segment depression. PR segment depression is in pericarditis. What you see is electrical alternations. Big complex, small complex, big complex, small complex. As the heart goes backwards and forwards in the chest, big complex, small complexes. The initial therapy for pericardial tamponade is to give a needle in the chest. Diuretics will be fatal. Diuretics will be fatal because if you have a person who is having a heart that's being squeezed and you give a diuretic and make them lose intravascular volume, the heart will squeeze even more and it'll squeeze the life out of you. Diuretics are fatal. Pericardiocentesis, put a needle in that heart under the xiphoid process, pull out a fluid, and the heart re-expands. The long-term therapy is a window. What's a window in my pericardium? A window? Well, it's just a fancy way of saying a hole. But you don't want to say that. Doctor, 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 what are you going to do to my husband? I'm going to put a hole into his heart. Doctor, 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 what are you going to do to my husband? I'm going to put a window into his heart. You can look in anytime you want. Isn't that great? It sounds better. Which Swan-Ganz catheter value is found in tamponade? An elevated wedgie? Do you get an elevated wedgie? No. Elevated wedge, decreased cardiac output, increased resistance. That's congestive heart failure. Choice A. Hey, are we supposed to do? Hey, stop that. Why are you making these people? Hey, Fisher, why are you making these people learn swan readings? You're a very bad man. Bahut Buddha. Well, the answer is you're not supposed to do the Swan-Ganz, but you have to know what it shows. Swan-Ganz catheter with this value, choice A is pulmonary edema. Decreased wedge, decreased cardiac output, increased systemic vascular resistance. Choice B is volume depletion. Volume depletion, like bleeding or dehydration. Choice C, a step up in saturation as you go from the right atrium to the right ventricle. Step up in saturation is ventricular septal defect. Decreased wedge, increased cardiac output, decreased resistance, decreased systemic vascular resistance. Choice D is sepsis. Sepsis. I bet you're thinking that no matter what the last choice is, since I just said the other things are different, that the last answer is probably right. You know, the other way to say it is, choose the answer with the largest number of words. equalization of all pressures in all the ventricles, all the chambers in diastole. Diastolic equalization of pressures. And the answer is E, equalization of all pressures, because the heart is equally compressed, so all the pressures are equal. What are we giving the Vietnamese? What are we giving you people for beating us in a war? Okay? Let's give them progressively worsening shortness of breath, edema, right-sided failure. Ascites, right-sided failure. Shortness of breath, right-sided failure. Looks like cor pulmonale, doesn't it? Increased jugular venous pressure, right-sided failure. Looks like jugular venous distension. Edema, ascites, big liver, big spleen. Now, what's the difference between this and cor pulmonale, just right ventricular hypertrophy? And the answer is the extra sound. The heart can't fill, the heart can't fill. The heart can't fill and you get a. The heart can't fill and you get a. The heart can't fill and you get an extra knock. You get an extra knock. Pericardial knock, that hurt. Pericardial knock. The EKG shows low voltage. Why? Because it's encased with a calcified fibrotic pericardium. A calcified fibrotic pericardium. Extra heart sound, that's a pericardial knock. Signs of right-sided heart failure with a knock and calcifications. And the same thing seen on a CAT scan. Pericarditis is a functional disease. Pericarditis. It's inflammatory function. The heart sac, the pericardium becomes inflamed with infection or trauma or cancer. It has an inflammatory functional test called an EKG. It is an anti-inflammatory functional treatment, non-steroidals, colchicine, steroids. Tamponade is a hemodynamic disease. It's fluid compressing the heart. It's a hemodynamic disease. It's got hypotension, pulsus paradoxus, and jugular venous distension. It's a hemodynamic presentation. You take fluid out from around the heart. It's a hemodynamic treatment. You put a window so the fluid can continuously drain. It's got hemodynamic treatment. Constrictive pericarditis is an anatomic disease. Abnormalities in the anatomy of the size of the liver and the spleen. Abnormalities in the anatomy of your legs with edema and ascites. Abnormalities in the anatomy of your heart with calcification and fibrosis on CT, X-ray, and MRI. And it has an anatomic treatment. This is the calcified fibrotic pericardium, calcified and fibrotic, and calcified fibrotic pericardium. And it has an anatomic treatment. And the anatomic treatment is no medications will get rid of that fibrosis. It's an anatomic treatment called remove the pericardium. Which of these is most likely in this patient? Kussmaul sign, paradoxical split. I'm tired of hearing about paradoxical and wide splits. Well, you might say, how come you don't get a pulsus paradoxus in constrictive pericarditis? And why don't you get a Kussmaul's in pericardial tamponade? And the answer is you actually do. You get both in both. You can get pulsus paradoxus in constrictive pericarditis, and you can have a Kussmaul's in tamponade. It's just that tamponade mostly gives you pulsus paradoxus, and constrictive pericarditis mostly gives you Kussmaul sign. So you could have both, but Kussmaul sign. An increase in jugular venous pressure on inhalation. An increase in jugular venous pressure on inhalation. There's no medical therapy for constrictive pericarditis. The medical therapy is surgical removal. Okay, so by the way, why did we give the guy Vietnamese? And the answer is because there's almost no domestic constrictive pericarditis. Because constrictive pericarditis has to be long-term, long enough to calcify and fibrose. Long-term calcifying and fibrosis, untreated infection or uremia. But this is the American Board of Internal Medicine. And the American Board of Internal Medicine is a dialysis center on every street corner. So there's no bread and butter uremic pericarditis. There's no long-term untreated tuberculosis. So it has to be a place where you can have a long-term untreated infection like tuberculosis, and that's imported. So which of the following shows equalization? Equalization is in 3, 4, and only in constrictive and tamponade, because it's squeezing all the chambers equally. Now, which is associated? Oh, this is hard, isn't it? Which of these associated with constrictive pericarditis? Which of these associated? There's going to be choices in a minute. Which of these associated with a restrictive cardiomyopathy? Say along. Which of these associated with the tamponade? What's the choices? What's the choices? Or all of them, or none of them. Now, this is an educational device, so real boards don't do all the above and none of the above questions because those are old style, but this is for educational value because we're going to give you 10 answers in a row, and it's got to be one of these. So, which of these associate with rapid ventricular filling? Ooh, so these are the choices. Restrictive cardiomyopathy, what causes restrictive cardiomyopathy? Restrictive cardiomyopathy, sarcoidosis. Restrictive cardiomyopathy, amyloidosis, infiltrating the heart muscle. Restrictive cardiomyopathy, hemochromatosis, it's infiltrating the heart muscle. Restrictive cardiomyopathy, sarcoid, amyloid, hemochromatosis, cancer and fibrosis, sarcoid, amyloid, hemochromatosis, cancer and fibrosis. Which of these has rapid ventricular filling? And the answer is, constrictive pericarditis has rapid ventricular filling. Which of these has jugular venous distension? And they all have, okay? So you see those choices? Let's make sure you can see the choices again. Tamponade, restrictive and constrictive pericarditis. Only rapid ventricular filling, only with constrictive pericarditis. Jugular venous pressure increase is with all of them. Which of them has an abnormal EKG? Constrictive pericarditis, restrictive cardiomyopathy? It's mostly with tamponade because low voltage is a little too non-specific to have anything. See, tamponade and pericarditis is the only ones that have a specific abnormal EKG. Remember, electrical alternans? Which of these has calcifications? Can you remember? We said it almost a minute ago. The only one with calcifications is the constrictive pericarditis. Which of these has an increase in BNP? Well, anything that causes cardiac abnormality, but the thing is though, constrictive pericarditis is not a cardiac abnormality, is it? Oh, that's right. It's not a cardiomyopathy. Any cardiomyopathy. But you see, tamponade and constrictive pericarditis are not cardiomyopathies, are they? They're pericardial problems. Which of these is associated with pulmonary hypertension? Restrictive cardiomyopathy is the only one with pulmonary hypertension because it happens because pulmonary hypertension because of the increased pressures going through the heart. Which of these gets worsened with diuretics? Ooh, that's where the fluid is compressing the heart from the outside. Because the fluid is compressing the heart from the outside, giving diuretics will make the heart collapse even more if you have tamponade. But there's restrictive cardiomyopathy and constrictive pericarditis. Very difficult words, aren't they? Restrictive cardiomyopathy and constrictive pericarditis have edema and ascites and big liver and big spleen, and edema and ascites and big liver and big spleen. And that's why restrictive cardiomyopathy and constrictive pericarditis can both get improved with diuretics. Ooh, they all have a prominent X descent, which is to say, a rapid filling, dropping of pressure, rapid dropping of pressure in diastole. Okay, prominent X descent is rapid drop in pressure in diastole. Which of these gets better? Well, if tamponade is worsened by giving diuretics, that means that tamponade is improved by giving fluids because it pushes the right side of the heart open, it pushes the heart open, it increases the intracardiac pressure to push back against the tamponading fluid. Giving IV fluids increases the intracardiac pressure and it pushes back against the tamponading fluids. Oh, where'd we go? That's it, I'm back. Ha ha ha, did you miss me? And none of them get better with ACE inhibitors. Congenital heart disease. Rather than say how difficult that was, why not say, wow, these were diseases I always avoided. I never wanted to learn them. And the good news is the answers in congenital heart disease management and pericarditis are never gonna change.